Idea of accepting these sessions is practically this, that gives us a chance to interact and meet all of you, because with the busy kind of schedule which we have, at times it becomes difficult, 6 months, 1 year, before really we converse or interact like these on short forums. So it's a proud and privilege to be standing here in front of you again, which we keep on trying, that at least 3 monthly we should be doing, so we should be part of some forum standing in front of you. So this is one. But before I really move and start with my deliberation, I think compliments to Cadila. So absolutely wonderful, pretty exciting. I was really surprised to know once Mr. O.P. Singh, the president of Cadila, he was mentioning about this program, the vast scale of this program. I think it's really amazing. One, not only CMEs, so CMEs and scientific conclaves are just a part of this, but more than that, what excites me more is the kind of work by which they are honoring the young, budding medicos. Like, one medico was honored here. So my congrats to Mr. Dr. Rakesh Das also. But endeavor, tells that you are really thinking, innovating, and doing the best thing in the society, because I personally feel the dissemination of knowledge, nothing is better than that. That is the most wonderful thing in the society. If you disseminate the scientific knowledge or the encouragement down, which percolates down to the society, that is the wonderful feeling and the wonderful scenario which you people are doing. So hats off. And other than that, I think it's very well organized. So Mr. S.B. Singh, your promotion is almost certain. So I think I straight away move to the topic. I already quite a lot of time and two speakers in line also. I'm an interventional cardiologist. So having been told that I have to speak on hypertension. Hypertension is one area which, we widely come across patients in our clinical practice. Not only we as cardiologists, but all physicians. I think maybe you are seeing more hypertensive patients than a cardiologist at a tertiary level hospital. So you would agree with me that there are still many controversies in the field of management of hypertension. So my endeavor is just to sum up those controversies and to find a solution to those controversies, so that we know at the end of the talk that at least we have some eased out summarizations and solutions to such controversies, if at all they are existing in the field of management of hypertension. So the outline of the talk is, one, we'll talk of Indian scenario of hypertension, history and blood pressure measurement. We'll just go through the historical background, as there was some statement that innovation is the thing, and it's a proud thing to announce that I think cardiology is one area where maximum perhaps the innovations happened in this area, ranging from molecules to complex procedures. Now we are doing a valve replacement without a surgical incision on the body. So such is the scale of innovations in the field of cardiology. Ambulatory blood pressure monitoring, I think it's really underutilized. So this is again a modality which is pretty handy in trying to solve the magnitude of hypertension and trying to treat the patients of hypertension with a better frame of mind, better wisdom. So this is one area which we frequently used at our institute, and it is really beneficial for certain complex patients. Guidelines of hypertension, similarities and difference. We'll just go through few slides where we'll talk of various guidelines, JNC and European Society of Cardiology. So recent trials, there are two trials which, in brief, I'll just touch upon SPRINT and HOPE-3. I think these are the trials which change the way we should practice. And certain special subsets like diabetes and CKD, and then something happening in chronopharmacology. So what is this? I think still there is some issue related to the timing of antihypertensive pills, whether it should be given in the morning, evening, or at the bedtime. So which is superior to the other? We still are actually lacking data in this regard. So we'll talk of that and then a concluding slide. So let's see the Indian scenario. Prevalence, as I said, is quite significant. It's not less. Almost 30% of Indian population is hypertensive. But the problem is not this. Problem is here. The prevalence of hypertension, as I mentioned, is around 30% rural and urban. There is no much gap between rural and urban. Proportion of patients aware of hypertensive status is again highly significant, almost 40%. Is the proportion who are only aware. 60% they are not aware they are hypertensive. Proportion of hypertensives being treated. Now see, these four things tell us that if once we come down the ladder, it's really difficult. The proportion where people are aware, proportion which actually is getting good treatment, and the real crux which are achieving the full control of high blood pressure. Once we come down, we would accept this statement with dignity that despite all the efforts, the level of awareness about blood pressure is very low in India still, which is also evident with lower population of patients achieving optimal control. So all of you would agree with this. Now if we just go through few slides of the historical background, it all started in 1733 when Stephen Hales first measured blood pressure, and it was really clumsy the way he measured the blood pressure first. So he measured the blood pressure actually cannulating the carotid artery of a horse with a brass pipe. This diagram tells you. He cannulated the carotid artery and then see the column moving. This is how it all started, and then the BP apparatus which we use so frequently nowadays. 100 years later, a mercury manometer connected with the artery that was also invasive, and then 1890s, the Riva Rocky invented the real sphygmomanometer, and this is how we started measuring the blood pressure, which we very frequently and routinely do in our practice. Now Indian guidelines, or the way ideal method how we should really attempt, how we should really measure the blood pressure. Normally it should be 3 readings, and average of 3 readings should be recorded. 3 readings should be recorded and average taken out of this. Patients should be asked to refrain from smoking or drinking tea or coffee at least 30 minutes prior to measuring BP. Now this is very important. Once we see the results of various trials, we come to know this is important to pinpoint the smaller trivial issues related to BP measurement. Allow the patient to sit for at least 5 minutes in a quiet room before beginning the blood pressure measurement. I'm just putting some emphasis on these points. These are very important points. Measurement should be done preferably in a sitting or supine position and not in a standing position. Patient's arm should be fully supported at the level of heart. Measure the blood pressure in both arms at the first visit and use higher of the 2 readings. I'll skip one slide. Now ambulatory blood pressure monitoring. As I mentioned, this is very important area which is still quite underutilized. Now it gives us an information of 24-hour BP recordings as well as mean values over defined periods of time such as day, night, morning. So it's recording constantly until the device is attached. The information which it gives, which is very important, whether one, obviously it gives us information that once the patient is being recorded a high blood pressure in a doctor's clinic, So it could be white coat hypertension. So it negates that if at all it was only white coat hypertension. But another thing which it tells us, that while sleeping, whether the physiological dipping of blood pressure is happening or not. Now, wherever the physiological decline in blood pressure is not happening while patient is asleep, those patients are also predisposed for more cardiovascular events. So these are called non-dippers, and they are pretty vulnerable for more cardiovascular events. So indications wise, white coat hypertension, isolated systolic hypertension, nocturnal blood pressure, resistant hypertension, and where there are some confusing symptoms happening. Now, other thing we know in awake patients where what are the abnormal readings more than 140 and 90, but the lower line is also very important, that while the patient is asleep and patient is on ambulatory BP monitoring, the abnormal pressures are more than 125 and 65. Limitations, I don't find any limitation except for cost, and maybe patient feels slightly cumbersome with the device attached. So it is quite of a value in selected patients. Now let's see the guidelines. Let's see, are there real differences once we talk of JNC guidelines or European Society of Hypertension or European Society of Cardiology or American Society of Hypertension. Practically not much. So JNC 8 slightly changed the guidelines this last time once it was there. So 140/90 is the limit beyond which we say the patient now requires a drug therapy. It is applicable to less than 60 years of patient, of 60 years of person, but more than 60 years, 150/90 is the threshold. So that was changed this time. However, in JNC 7 this limit was only 1. So this was one change as far as the threshold for antihypertensive medicines are concerned. Mostly it is the same. So let's not discuss that. Indian scenario, there is slight change, here, but I think this is again a cumbersome slide. But practically what I tell you, the beta blockers took the back seat with certain trials as a solo therapy for hypertension or a first line therapy. Now they are considered as a weak antihypertensive agents, but in Indian settings, in younger patients, still beta blockers are more frequently used as compared to the global scenario. The fixed dose combinations, there are still some debates as regards to this issue, but no confusion that fixed dose combinations, the polypill, is going to increase the compliance. And once the compliance is increased, I think the strict BP control, more strict BP control is achieved in a patient. So that has an advantage, definitely. And obviously, once you are dealing with a patient who's a multiple risk factor profile like CAD, diabetic, so this polypill has more value in such type of subsets. So as I mentioned, in younger hypertensive, beta blocker still is frequently recommended. Chlorthalidone, that is another thing which will come up with Hope 3 will discuss. Chlorthalidone perhaps is acting better than hydrochlorothiazide. So I think now in Indian market we have more combinations with chlorthalidone. Previously we only had combinations with hydrochlorothiazide. So, and the research has shown that chlorthalidone with other combinations is working better than hydrochlorothiazide. Beta blockers, the real antihypertensive role of beta blockers has been questioned, and the basis is practically these two trials. The LIVE study clearly showed that atenolol was significantly less effective than losartan, and ASCOT study also showed that this was not really there once we talk of antihypertensive effect of beta blockers. But this only tested the previous generation beta blockers. Now we have beta blockers with more vasodilatory effects. So I am talking of nebivolol things, third generation vasodilating beta blockers. So practically these beta blockers, they haven't been tested. So we can't say really beta blockers are totally out, but yes, they are lower down the ladder now. The recent trials and the practical implications. I'm coming to two trials. I'll just take 2-3 minutes each with SPRINT and then HOPE-3. These are very important trials in the field of management of hypertension. So what SPRINT proved? Now SPRINT actually was tested that if we control the blood pressure in a modest way or control the blood pressure in a meticulous, judicious way, if we take down the blood pressure lesser than 120 and 80 millimeter of mercury, whether it is more effective, whether it is giving more survival benefit or decreasing or improving the outcomes further as compared to 140/90. So this really opened the Pandora's box, that once we are talking of controlling the blood pressure, if we control the blood pressure more judiciously and take it down to lower limits, more lower limits, 120 and 80, the cardiovascular outcomes are much better in that subset as compared to 140 and 90. So this is the synopsis of the SPRINT trial, and this graph shows the gap in yellow and the blue line. The yellow one is more intensive treatment. So outcomes are far better in once we take the blood pressure further down with the intensive management. The conclusion of SPRINT trial is that benefit of more intensive BP lowering is very significant irrespective of gender or race, and also this gets extended to the aging population also. So implications, I think this is one area I can skip this easily. So this also, SPRINT also proved that chlorthalidone was a thiazide type of diuretic of choice for the trial. Amlodipine was calcium channel blocker of choice. Beta blockers are now considered to be less effective in preventing CVD events as primary treatment of hypertension. So this was SPRINT and HOPE-3. Now again, this is important. Now what it tested, that once we are talking of dyslipidemia and hypertension together, which is a very frequent combination in our practice. So once we are talking of hypertensive patients with dyslipidemia, if we combine the lipid lowering with antihypertensive therapy, that gives us much better outcomes. But does this outcome also applicable to the subset once the BP is not into the higher range? Suppose if the blood pressure is 130/80 and there is dyslipidemia. This trial tested that antihypertensives and the cholesterol lowering together in this subset, is it really working? I'll give you the summarization, the final point. Hypertensive patients with dyslipidemia, the combined therapy was working in terms of improving the outcomes, but where the blood pressure was already in normal range, this therapy was not working. So this is about HOPE-3. So these are some important trials which came out recently and changed the way we practice. So our findings contradict lower is better hypothesis. This is all, and I think it's compatible with the hypothesis that treating the persons without cardiovascular disease who have systolic blood pressure above 140 appears to be beneficial, but treatment would not be of benefit and may even be of certain harm with lower systolic blood pressures. Hypertension in diabetes and kidneys. Accord BP was one trial, I think. So we can skip that. Now the goal of blood pressure with various all the guidelines. Practically you need to know about the 140/90. We should lower the blood pressure below this range, except that if there is a significant proteinuria. If there is a significant proteinuria, this level goes down to 130 and 80. So we should be more aggressive, especially in this subset, that take it down. But sprint proved that we should take it down further, then outcomes are better. Chronopharmacology, as I mentioned, there is still a debatable issue when what is the ideal time to give the antihypertensive pills. We have certain evidence in terms of data. This review was done in 2011, and it showed that better BP control perhaps with a bedtime dosing. The clinical significance of which is not known. We don't have a data whether morning dose is absolutely required, but on the contrary, it is proving that evening dose is better. So morning versus evening, there are many trials in pipeline which will clarify the issue further. So I am coming to the last slide. Hypertension remains a condition of public health importance in India. It is actually engulfing big strata of our society, significant population. The methodology to measure accurate blood pressure should be given a due importance, which all the steps we have talked about. This is very important exactly to know that how to have ideal blood pressure recording. Ambulatory blood pressure recording should be more used in more confusing and complex patients. The recent trials have provided useful information for lowering the blood pressure further. The usual goals of blood pressure should be followed. The BP goals can be lowered further in some special situations, like I mentioned, the significant proteinuria. The choice of drugs for controlling blood pressure, I think it's absolutely individualized. We know that how to go about it. We can start with one pill, increase the dosage to the maximum, wait for certain days, and then add on another pill. Till more data emerge, the evening dose of antihypertensive can be advised, and it is high time that India has its own CV outcome trials. That is where I think we are still lacking. We should have our own personal data in India, because I personally feel that Indian Indian population is different. I'll end my talk with a small 2 lines in Hindi. I think a lot of talk of innovation and other things. Very simplified. जिंदगी तुझसे सिर्फ एक ही ख्वाहिश है, तेरा हर एक लम्हा पिछले से बेहतर हो. Thank you very much.